Today we're coming to you live from the American Orthopedic Society for Sports Medicine annual meeting in Seattle, Washington. The AOSSM annual meeting is the premier sports medicine conference each year, hosting thousands of attendees with hundreds of poster and paper presentations, exhibitors, and instructional course lecturers. This year proved to be as spectacular as years past. We were fortunate to have the opportunity to catch up with many of the presenters at the meeting and get their take on some of the hottest topics in sports medicine. Over these 7 episodes, we're going to be exploring some cutting-edge sports medicine with these experts who are presenting at the meeting. These episodes are brought to you by Arthrex, a global leader in minimally invasive orthopedic technology and surgical education. We appreciate their continued support of this podcast, as well as their commitment to advancing innovation in sports medicine and helping surgeons develop technologies that continue to improve patient care. Welcome to the Sports Stacks podcast. So metal buttons have long been the standard in ACL reconstruction, but all-suture fixation could very well represent the next evolution. In this episode, we are joined by Dr. Seth Sherman, orthopedic surgeon for Stanford Cardinal Football and sports medicine fellowship director at Stanford Health. He will discuss the Arthrex TightRope SB implant and the growing role of all-suture button technology in ACL reconstruction.
All right, so featuring a low-profile radiopaque all-suture design, the TightRope SB eliminates metal while maintaining the benefits of adjustable loop fixation. So Dr. Sherman's going to give his perspective on transitioning to this technology and where it fits in his ACL reconstruction practice. So welcome. You've been on the show before. We're very excited to have you.
Thank you. I'm excited to be back. I'm a veteran.
Welcome back.
This is great energy today. Great first day of the meeting.
Yes.
Yeah, it's been a great meeting so far.
So suspensory fixation has really been the workhorse for soft tissue graft fixation over the last decade, but innovation really hasn't stopped there. And today, as Catherine mentioned, we're going to explore what has changed, why it matters, and whether all-suture cortical fixation represents the future of ACL surgery. So before we do that, though, we want to talk about graft choice. That obviously impacts graft fixation selection. So Seth, can you walk us through your thought process for selecting the best graft for a patient? What factors are you considering, and what's your favorite?
For sure. We had a great session this morning that teased a lot of these points, but I think probably the biggest thing to teach young people is that you need a lot of tools in the toolbox, right? So I'm not a one-horse pony with my grafts. I like to be able to do them all so that I can choose the right one for each patient. That said, at this point, I'm probably 70% quad, about 20% BTB, and then 10% will be primary repair and allograft. I tend to use autografts when people are young and active, and I try to use BTB in those under 21, NCAA, future NBA, NFL type people, and our young female athletes. And then in that 25 to 40-year-old, I think the quad's been a really nice game changer. I will admit here that I really haven't done a hamstring in a very, very long time.
Same.
I just think that taking from the anterior chain has worked for me, and really with the advent of the quad, and then with the older patients, properly selected allografts and proximal primary repairs, really haven't had a need to go back to hamstring.
Absolutely.
Yeah, I love that. I think a lot of times people do get tunnel vision where they start to say, this is my graft and this is what I do. But as you're saying, there's a lot of different options out there, and being skilled in multiple is important.
Yeah, and we heard a great talk from Liz Madskin today, and most of the world is still doing hamstrings, and if you do hamstrings with ALL or LET, it's fine. So you have to just know what you're doing and pick what's good in your hands.
Yeah, good point. We trained under Madskin and saw excellent outcomes in our hands.
She must be sad right now with this. And Bernie Bach's going to kill me that I'm not all BTB, but such is life, evolution. He's here, isn't he?
Probably. So similar to graft choice, we also have graft fixation choice, which has evolved over the years. So whether it's metal screw in the femur or moving towards suspensory fixation. So talk a little bit about how that choice has changed for you over time.
Yeah, I think over the past decade or so, I moved to a BTB button on the femoral side for multiple reasons. One, I could deal with mismatch.
Sure.
2, so I can just pull it up into the tunnel. 2, I can, I have nothing at the aperture if it fails. I can revise it easily. And 3, I can do my screw on the tibia. I still use a metal screw, and then retention on the femur. So that was a big step for me, from metal screw. And then when the quad came into vogue, then I had to really go back to just soft tissue and soft tissue fixation. And that that moved into the button world, right? Cool. And I think that was a hard evolution to prove to yourself that it's as strong to start early range of motion and to really get similar feel and findings as the B2B. So that was kind of the first move to metallic, of course.
So you mentioning retensioning, and retensioning of that tightrope device really is key to dial in that tension, avoid any laxity. So what initially caught your attention about this new tightrope SB device? What are some of the benefits compared to the traditional tightrope that you started to use?
Yeah, I think first and foremost, if we can get similar or better, kind of outcomes with something all suture instead of metallic, I think that's probably something that we're all thinking about. If you have for example, any kind of non-metallic implant that's strong, I think that's great. The soft button tightrope is stronger than the standard tightrope, so that's one thing that stood out. I think ultimately, and we'll probably get to this, this is the first of, I think, multi-generations and more of a philosophical type move in a direction, and we have to start somewhere. So for me, it was exciting to move to something that was as strong or stronger, that was all suture, that ultimately might not show up on x-rays, and other advantages we'll get into.
Absolutely.
Yeah.
Sure. When you are doing this procedure, for someone who has not tried it yet, does it feel different to you? Does it feel, you're mentioning it's strong, but tell us a little bit more about how does that actually feel?
Yeah, I think it's interesting. There's always a learning curve with any novel technology. I'm still using fluoro to do it. You can see that it's radiopaque, so you make sure that it's on the cortex. And at the end of the day, even if you struggle in a slight learning curve, as long as it ends up being where you want it to be, that's okay. And then the next case will be easier, and the next one, and the next one. It's not a very big learning curve, but it is different. You actually can have one person who's in charge of getting the graft from outside the joint to the far cortex, and so one person is just holding the graft and the other person is basically moving the soft button tightrope themselves. What's interesting about it, initially you lengthen it and you can kind of crimp it down so it's just straight in line, and then you can feel that it goes past the cortex, so you lose that resistance. Then you pull back on the graft and it balls up on itself. And so once you do that once or twice, and if you see it on a sawbone or you do it in a cadaver, I think that those are very logical things to do before you try any new technology. So of course we did all of that, and we studied the biomechanical data that came out before ever introducing it.
Cool. Now, you mentioned one of the benefits of this all-suture button is eliminating the metal. So can you talk about the clinical differences you see with eliminating metal? Why should that matter to people and patients?
Yeah, I think, I think Rachel has a great looking slide on this multi-lig that has it's metallosis, and that patient, it's not their last surgery, unfortunately. Well, it is for now. She did a great job, but multi-ligs are a big deal, and that's probably going to come back, and it's going to need removals of hardware, and those hardware removals can be challenging. They can leave bone voids, and so I think that doing the exact same surgery with something that's just suture and that you can just cut out easily, or frankly leave or drill through or around, those are huge advantages. When you show patients something with a scatter of metal versus something that just is basically invisible, I think in general people would like that if all things are considered equal. And I think that, again, it's a platform type technology, so I think us as surgeons and partnering with industry will get creative and we'll find whatever the next true advantages are. So maybe at time zero, besides the strength aspects and the x-ray aspects, there's not a million things that jump out either in studies or otherwise, but it's just the beginning. And it's the same or will be better.
Yeah. Absolutely. Yeah, I think those are all great points. And that slide, I saw that on LinkedIn from Rachel Frank. We'll have to post that on our socials. I think that's really, it's a really perfect way to just demonstrate all that metal that can just take over the entire knee. And then you think about down the line, okay, what's going to happen? Are they going to go to a total joint someday? And what's going to be left for that surgeon? And, so.
And for those of us who do this surgery, ACL surgery a lot, and you have to flip buttons, and you flip them on the IT band. There's nothing more annoying than when the metal button is caught outside the IT band, and then you have to make an incision. You have to follow it down. It's usually more posterior or proximal than you'd like, and so that's a nightmare. And so with the soft button, you can pull it all the way through, make sure it's elongated, and then just bring it right back. And so that is another huge advantage not to be overlooked, I think, for like anyone in their learning curve.
So in the OR, a lot of people will use fluoroscopy to check their button. We mentioned that the soft button is radiopaque. Do you use fluoroscopy intraoperatively? Do you need to, or is that something you'd suggest early on?
Yeah, I would definitely suggest it early on. I'm a big, like the large C-arm kind of user, but I do a lot of osteotomy and other things, so it's there. I understand, and it's certainly acceptable for this just to use a small C-arm, and then you don't have to put lead on. A lot of people don't like to do that, but I think going through the fluoro steps of seeing it elongated, seeing it getting just through that cortex, then past it, then pulling back on the graft, seeing it ball up, and then pulling as hard as you possibly can, and proving to yourself how stable it is before you dock the tendon. I mean, that on fluoro is just a really important adventure.
Yeah.
Now, I know you mentioned that we still have yet to really learn the true benefits of being all suture, but what are your thoughts on the low profile design in terms of how it may cause a difference in soft tissue interaction, right? People are all worried about metal. What are your thoughts on that in terms of minimizing soft tissue irritation?
Yeah, I think it can be a huge advantage. Certainly on the tibial side, when we're using this, we could do what's called the technical smoosh technique. So you just take a tam.
Is that real?
Yeah,
That's
real?
published,
Yeah.
not published, but that's what we call it.
Okay.
So you smoosh it down. You take a tamp and you mallet, and it flattens out the suture, so you really won't or don't feel it. So I don't know. I don't take out that many metal buttons, but I take out enough that it matters. And I've not seen any soft tissue irritation with that suture. And also, I feel more comfortable if things are going to, at any point, break, move, migrate. Having a suture break, move, or migrate versus like a metal button that's starting to make its way down to the back of the knee.
Yeah.
Which one would you choose?
Yeah, absolutely.
Big deal. So I think you probably know surgeons don't like change. We don't like change. We've talked a little bit in bits and pieces about just tips and tricks. But as a whole, if a surgeon is going to make this change, walk us through your advice.
Yeah, I think it's important to know the existing information. That's the background and the basic biomechanics of it. So then I think it's important to not have your rep teach you while you're in the operative theater, because
Never
that's
a good
stressful.
thing.
So you want to do it in a controlled setting. I would strongly advise, if you have PAs or athletic trainers or whoever you work with, or your residents or fellows, to have them there too, because it's always a team effort when you're adopting to new technologies, and it's way less stressful if the team is on the same page. And again, you're not the only one who sort of knows, and the rep, and then you're teaching people who've never seen it before. Recipe for disaster. So with any novel tech, there's a learning curve like that. And then, I think just going slow to go fast. Every step needs to make sense. So if something is not looking or feeling or acting right, don't just brutane it. It's not going to make it better. It'll make it worse. So, I go fast and efficiently in the OR because every step is slow and methodical. And I think in adopting to new technologies like a soft button tightrope, you want to think through your head, what's the next step? What's the next step? Is this feeling right? This is a little strange. Is that too much resistance or too little? Maybe I'll take the fluoro shot. Where am I? And do all those steps in that order. And then it's really not terribly challenging. It's a different order of operations, as we said, and different manpower, like who's doing what, than the metal buttons. But once you get that down, it's really it's not stressful.
That's great.
So another advancement in the field of ACL reconstruction that we wanted to talk about is the internal brace. And we're going to get into how that plugs into the TightRope SB. But first, why should surgeons consider adding an internal brace to their ACL reconstructions? What does it add?
Yeah, I think I was fortunate. I was at University of Missouri for almost 9 years. My partner, head team doc at the time, Pat Smith, was really one of the, I would say, pioneers of that concept. Has as much, if not more, of the data from start to finish, the model of how you would study a new concept, new technology, new idea in animals, safety first, then kind of moving towards human clinical, and then even looking at comparative studies. And so it's been a really long time coming. The ACL data is out there now as far as why it's important to have this kind of protector, seatbelt. Bruce Levy has shown also the PCL data. So I think this is really like the second round of adoption of internal bracing, and almost to the point for a lot of us, especially with soft tissue grafts, asking why are you not doing it? Because it's not a synthetic ligament. It is not unsafe to the joint. It is not going to stress shield your ACL. You know, all these myths, and I went through them at a meeting last year. It doesn't do any of that. If you do it appropriately, it's a protector of the ACL. When you're about to pivot shift, you're about to destroy that graft, it comes tight, it load shares, and maybe it ruptures first or just stops the catastrophe. And that's kind of the whole concept. Otherwise, it's along for the ride.
What if you could get Gait Laboratory insights from a simple foot insole in just 3 minutes? With Ballaston Health's AI MoveScan, you can. AI MoveScan brings clinical-grade movement analysis directly into everyday patient evaluations. Simply place the sensorized insole into your patient's own shoe and have them walk, run, or jump naturally. There is no complex setup, no calibration, no markers, and no treadmill required. In less than 3 minutes, you receive a clear, actionable report with more than 30 validated biomechanical parameters to help evaluate movement quality, monitor rehabilitation progress, and support more informed treatment decisions. What makes the platform even more powerful is its integrated AI assistant. Built within a closed model, the AI assistant helps clinicians better understand the movement data, identify meaningful trends, and connect objective biomechanics to clinical decision-making. And the results are backed by data. AI MoveScan has demonstrated 95% agreement with optical motion capture, which is the research-grade gold standard in peer review validation. Whether you are evaluating recovery, monitoring progress, or helping guide return-to-play decisions, AI MoveScan brings objective movement data and AI-supported insights into everyday clinical practice. To schedule your personalized demo, email sales@bracelab.com and mention the sports docs. Learn more at bracelab.com. Every patient has a goal: getting back on the court, returning to the trails, staying active with family and friends. At JRF Ortho, they are proud to help surgeons make those goals possible through industry-leading allograft solutions and one of the largest inventories of fresh osteochondral allografts available. For more than 20 years, JRF Ortho has partnered with surgeons to restore damaged cartilage and bone using fresh OCAs that contain living hyaline cartilage and viable chondrocytes. By preserving native joint mechanics, osteochondral allografts continue to play an important role in joint preservation and helping patients maintain active lifestyles. With more than 30,000 allografts distributed worldwide, JRF Ortho is trusted for innovation, superior customer care, and the highest quality products. And they make ordering JRF Ortho easy. Whether you have a specific surgery date, a preferred date range, or simply need the earliest available graft, their dedicated allograft solutions coordinators work with you every step of the way to identify, match, and deliver the right graft for your patient. From femoral condyles, talus, patella, distal tibia, to meniscus, tendons, and OCA cores, JRF Ortho provides the grafts, the experience, and the support that you need to move patients forward. JRF Ortho, 20 years of excellence in motion. Visit jrfortho.org to learn more.
Yeah. You know, we had Pat Smith on our show earlier this year, and I think you're exactly right. There's sort of this second wave of adoption where people are like, why are you not doing this? Like, we have to sort of reflect on, he has great data, so I echo that. I think one of the things that is still out there that people get concerned about is over-constraint. So how would you avoid over-constraining?
Yeah, and I'd also say, you know, internal bracing and other joints for other ligament problems. So you can look at prostrums, you can look at UCL. I mean, so really, you know, when a concept works and you apply it to other joints and it's also working with a different subset of doctors, and, you know, then you should open your eyes to it and adopt it. But you know, the over-constraint issue, I think it's all about technique. So it's part of or attached to your metal or soft tissue button on the femur, and then the internal brace is absolutely and independently tensioned from your ACL graft on the tibia. So it's fixated with, you know, in our case, a swivel lock, but in general, like whatever soft tissue anchor you're using, and it's in full hyperextension. And I do that before I do my ACL reconstruction. And so then I'll do my ACL usually at 0 to 5 degrees, something of this nature, and that's after the internal brace. And so they're really like the internal brace is slack through a lot of that flexion arc until you're getting to a point where you're about to start kind of giving way. And I think if you do it that way, the independent tensioning, then your risk of over constraint. I mean, the catastrophe for us, miserable patients lose extension.
Yeah.
People tolerate a bit of flexion, or you can get it later.
Yeah.
But if you capture extension, you're toast. And so if you do this wrong, or you try to do this together with your ACL, just to save steps or whatever, you can introduce challenge or harm.
Yeah. Great tips.
Yeah, good tips. So now we want to talk about how the TightRope SB incorporates the internal brace compared to the traditional traditional TightRope. So how is it different from?
Yeah, I think of all the things with the system, well, I'm not on the back table preparing things, but it can be some challenges with the older way that's just more streamlined with the soft button tight ropes. But in general, I think where I save time with the soft button is on the tibial side, because once I don't have to I can't see anymore. I'm 47 years old, so it's very hard to load those suture loops through buttons, and it's always frustrating. And I also am not great at just letting other people do everything. So I have a little bit of a control problem in nowhere. Do you have that?
No, never.
Absolutely.
I don't know what you're talking about.
But I find that the time saving for the soft button on the tibial side, it's 2 minutes every case. That's shorter than my medal, so that's 2 times, let's say 3 or 4 times X amount of ACLs a year. So that's more time with my kid.
Yeah,
it's
absolutely.
Yeah, that is exciting. Yeah. As far as integration with the internal brace, does that give you any confidence with rehab protocols, allowing them to be a little bit more aggressive in early stages, or same?
No, I think in general we've evolved to be pretty aggressive with our ACL rehabilitations. I think it's clearly driven by meniscus pathology and the complexities of meniscus. So I'm going to try to weight bear range, get full extension. I think initially in my evolution, if people are going from BTB to soft tissue quad, hamstring, or allograft, you're going to be more scared of that and stretching out, and that's probably the situation where it would definitely give you more comfort. But I think for us in this mid-evolution of it, it's go, go, go. Yeah. I would say we shouldn't, across the world, they're not bracing their regular ACLs. We're a brace-heavy nation, so just food for thought for a different time, but I would be probably comfortable and confident moving in that direction too.
So we want to wrap up with a big picture question, which I think you've been alluding to this entire episode. So do you see all suture fixation like the TightRope SB as a niche option, or do you think it represents a broader shift away from metal in the field of ACL reconstruction?
Yeah, I most certainly feel that all of these suture iterations are a move in the right direction. They bring out our inner, craving for innovation and problem solving, and I think the suture, the anchor platforms, the FiberTac platform has revolutionized a lot of the other things we do on the sides of the knee.
So
I tend to like to do hybrid fixation, so a soft button like a tightrope on one side of the joint. I will fix with all-suture tack on the other side of the joint, and then I can come back and retension. So I love those kind of constructs for MCLs or posterolateral corners, and frankly, we can continue to evolve techniques. I use the soft button tightrope to dock my femoral side of my MPFL, and so I think as we continue to do that, we'll just get more streamlined. We'll be able to really dial down and simplify the steps as our European friends come up with novel constructs. For example, looking at deep MCL reconstructions for external rotation with ACL, we can use our creative brains and we can adopt these kind of techniques and technologies to that very easily. Right? So I think that this is just the beginning. The more collaborators who have similar findings of the ease of transition, of the benefit to patients and good outcomes, I think that the better we'll all be.
Absolutely, great answer.
Yeah, absolutely. I think you've obviously highlighted a lot of great benefits to the patient, also to the surgeon, and I think as well as ease of integration into our practices. So As always, we love having you on the show and really appreciate how well you distill all these concepts. So thank you so much for
There's
coming.
Rachel Frank. We mentioned her. Hey, program chair.
We summoned her.
We gave you a shout out.
Yes.
You're going to be in the podcast.
Yeah.
We love you. Excellent. Well, I really appreciate being on. It was a lot of fun. As
It's
always.
always
so
great
much.
having you on the show.
Yeah.
Thank
You guys do a great job.
Appreciate it. Thank
ya.
you.
Thank you for listening to this episode of the Sports Talks podcast. We hope you enjoyed the discussion as much as we did. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and on YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review or comment. You can also reach us by email at thesportstalkspod@gmail.com or find us on Instagram at thesportstalkspod. We love your feedback.